approach. Now, let us talk about carcinoma breast. Most common site, most common type. Most common site of carcinoma breast is upper outer quadrant. Most common type is invasive ductal carcinoma, invasive ductal carcinoma, not otherwise specified. Invasive ductal carcinoma, not otherwise specified. Then comes the risk factors. In the risk factors for carcinoma breast, we have most important factor is advancing age. Advancing age. We have family history. Family history. Then any condition where there is increased endogenous estrogen exposure is there. So what are conditions where we get an endogenous estrogen exposure? One, good. Nulliparity, early menarche, late menopause, late first term pregnancy, and also obesity. These are the scenarios where you get increased endogenous estrogen exposure. Then high fatty diet, alcohol, oral contraceptive pills, important, and hormone replacement therapy also. Oral contraceptive pills and hormone replacement therapy also, right? And please note, smoking as an association with carcinoma breast, but it is not a direct risk factor. Smoking is not a direct risk factor for carcinoma breast. Smoking is not a direct risk factor for carcinoma breast. Important. Then protective factors. In protective factor, we have lactation and multiparity are the protective factors. Lactation and multiparity are the protective factors for carcinoma breast. Right now, we should know few points about a family history now. First of all, very important, very commonly checked also, and there is a lot of confusion also on this. The most common gene mutation associated with carcinoma breast, if asked, very commonly asked question. BRC1. You are absolutely wrong. It is P53. But if by any chance you are asked, most common gene mutation associated with familial or hereditary carcinoma breast, then the answer will be BRC1. Then it is BRC1. And one more question which is important. Most common gene mutation leading to carcinoma breast, if asked. Most common gene mutation leading to carcinoma breast, if also asked, then also it is BRCA1 followed by BRCA2. BRCA1 followed by a BRCA2. Right? Now, we should know this BRCA, few points about BRCA1 and BRCA2, the important points for us. First of all, can you tell me this BRCA1 or BRCA2, what type of genes are these? Are tumor suppressor genes or a proto-oncogene? Tumor suppressor. Two choices. These are tumor suppressor genes. अब पता लग गया? These are tumor suppressor genes. तो देखो, दो तरह के जीन्स है हमारी बॉडी. एक है प्रोटो-ऑन्कोजीन, एक एक है ट्यूमर सप्रेसर जीन। अगर प्रोटो ऑन्कोजीन ज्यादा प्रोलिफरेट करने लग जाते हैं और ट्यूमर सप्रेसर जीन कम हो जाते हैं तो सेल्स ज्यादा मल्टीप्लाई करते हैं। अगर प्रोटो ऑन्कोजीन्स में नॉर्मल है और ट्यूमर सप्रेसर जीन्स कम हो जाए तब भी प्रोटो ऑन्कोजीन्स मल्टीप्लाई ज्यादा करने लगे। तो दो तरह के जीन्स होते हैं, प्रोटो ऑन्कोजीन्स और ट्यूमर सप्रेसर। दीज आर ट्यूमर सप्रेसर, राइट? P53 is a proto oncogene. Okay, now this BRCA1 and BRCA2, very commonly asked, is located on chromosome number 17 and 13. 17 and 13. Right? Now, once this gene is mutated, be it 1 or be it 2, the most common malignancy the individual is going to develop is carcinoma breast. The most common malignancy they are going to develop is carcinoma breast, followed by very good. In both ovarian carcinoma, followed by ovarian carcinoma. Now, very, very important point is this carcinoma breast which this patient develops, there are certain features of this carcinoma breast. What are the features? We should know. This carcinoma breast which they develop is commonly bilateral in both. It is commonly multicentric also. And very, very important point to notice, in BRCA1 gene mutation individuals, the carcinoma breast which develops is poorly differentiated. Here it is well differentiated. And it is ER, PR, estrogen and progesterone receptors negative, and HER2 new receptor also negative. ER, PR, and HER2 new receptors, it will be negative. But here it is ER, PR positive, and HER2, it may be positive, it may be negative. And this is also called, important, triple negative. It is also called triple negative or basal-like. It is also called triple negative or basal-like. Important. Now, anyone who has a BRCA1 or BRCA2 gene mutation, very important discussion it is, will develop carcinoma breast at the percentage of 60 to 85%. So there are chances of that individual developing a carcinoma breast to such a great extent. So if anybody who is having a BRCA gene mutation, anyone who has a BRCA gene mutation, that individual is called high risk individual. An individual who has a BRCA gene mutation, an individual who has a BRCA gene mutation is called high risk individual. And the guideline says to this high risk individual, and the guideline says to this high risk individual, you should offer prophylactic bilateral mastectomy. Prophylactic bilateral mastectomy. Now imagine, this is something important. Imagine this is an individual who has no problem whatsoever. The only problem she has is she is having a BRC mutation, which she is not understanding, right? And you're telling her to get rid of both the breasts. So she may not accept this recommendation because not all females are as motivated as Angelina Jolie is, right? So if the female is not ready for this recommendation, so this is a recommendation by a WHO, but the WHO says if the female is not ready for this recommendation, you should put her on intensive surveillance. And how are we going to do that intensive surveillance? We will come to know. We should put this female on a intensive surveillance. And what is that intensive surveillance? We will understand. Regular checkup. And what is that regular checkup? Regular checkup. आते रहना, मिलते रहना. So what is that intensive surveillance? We will understand. So to a high risk female, we should offer a intensive surveillance. What is that intensive surveillance? Let's understand. Now, first of all, what is a screening protocol? Very important question. What is a screening protocol in a normal female? देखो क्या होता है? There is something called screening. We know carcinoma of breast is the most common malignancy worldwide, right? And since carcinoma of breast is very common, and with advancing age, the risk is increasing. So I told you, advancing age is the most important risk factor. So we want to find out a female who is developing a carcinoma of breast before it actually presents to us in the form of symptoms. We know that any lump becomes palpable. The most common presentation of a carcinoma of breast, you all know, is lump breast. Most common presentation of a carcinoma of breast is a lump breast, right? And the lump becomes palpable only when it is more than 1 centimeter. So we want to know those females who have still not developed the lump. There is a process started, but she has not developed the lump which she can feel at this moment. So we want to pick those females, and if we pick those females in that stage, obviously the survival of those females will be better. So this is called screening. So for certain malignancies, we do screenings. Breast is one of them. So we should know, for your examination point of view, you should know what in TSM it will be discussed. What all malignancies we do screening. Breast is one of the malignancy where we should be doing a screening. Now, how are we going to do screening? How will we pick these patients in an early stage? There are various ways to pick it. One, can anybody tell me what are the various ways? What? Staging. Self breast examination. Self breast examination. Now, when you say self breast examination, we have to know that how frequently are we going to do it and when are we going to start doing it. At what age we should start doing it? So can you tell me at what age we should start a self breast examination? 20, 25, 30, 35? 20? In this surgery discussion, you can check your guessing power also. In your exam, I'll be giving you choices and you should answer. And as in your exam, there is no negative marking. There is no negative marking here also. So, bindas, okay? Answer and check whether your guessing power is right, it's okay or not. And remember, एक ये basic rule है जो इस exam में तो apply नहीं कर रहा, but अगले exam में करेगा. जहाँ पे नेगेटिव मार्किंग होती है. जिस भी एग्जाम में नेगेटिव मार्किंग होती है और अगर आपको क्वेश्चन में हवा ही नहीं लग रही, यू आर नॉट अंडरस्टैंडिंग, कभी पढ़ा नहीं, कभी सुना नहीं, यू डोंट नो व्हाट दिस क्वेश्चन इज, इन दैट क्वेश्चन, इन अ नेगेटिव मार्किंग पेपर, it is better to leave that question. Sometimes it is better to swallow your ego. Don't take it on this. I have given a fees also to pura vasoolunga. Right? So don't answer that question. But if you can rule out two choices and you are struggling on two, always answer. Always take it on your ego and answer. And it is scientifically proven that whatever comes first is right. कितनी बार तुम्हारे साथ होता होगा कि मैंने मार्क किया था कुछ और, उसके बाद दिमाग में पता नहीं क्या है, उसको उठा के दूसरा कर दिया, पता लगा जो पहले वाला था वही ठीक था, और फिर यू कीप रिपेंटिंग कि क्यों किया मैंने ऐसा, राइट? तो whatever comes first is right. And remember, ये एक और इशू है एग्जाम में, आपको ये कंफ्यूजन हो जाता है कि what came first in mind. वहां तो कई तरह के गाने चल रहे थे. तो सेल्फ टेस्ट एग्जामिनेशन 20, 25, 30, 35, 25. So answer is 20. So don't guess. So you are very bad at guessing. So don't attempt that. But since there is no negative marking, we have to. And how frequently? Daily, monthly. Choices सुन लो पहले. Daily, monthly, 3 monthly, 6 monthly. 3 monthly. See, it's a self-based examination. So why do you want to wait for 3 months or 6 months? And at the same time, you should not be paranoid to do it daily. It is 20 years monthly. Clinical based examination should start at the age of 25 years. How frequently? 1 to 3 years till 40 years of age. Then annually. Clinical based examination should start at the age of 25 years, doing it 1 to 3 yearly till 40 years of age, then annually. Then comes mammogram. At what age? There is a lot of confusion on this question. Dekho, don't confuse a screening thing. We are talking about screening protocol. Don't confuse with the limitation of a mammogram, which I told you in the beginning. Less than 30, you will not do mammogram. More than 30, you do mammogram. That was a diagnostic mammogram. This is a screening. At what age? We should start a screening mammogram. 30, 35, 40, 45, 50, 55, 60. 35? 40 years, and we should do it annually. कब तक? जब तक है जान. At least till 75 years of age. At least till 75 years of age. Right? Now, then comes the intensive surveillance in a high risk individual. Intensive surveillance in a high risk individual will be same. The self-based examination is the same, but clinical based examination here should start at the age of 25 years, should be done 6 monthly. Here, a clinical based examination should be done 6 monthly. MRI is added here, should start at the age of 25 years, should be done annually. And as per the latest, mammogram should also be added here, started at the age of 30 years, doing it annually. This is the intensive surveillance in a high risk individual. This is the intensive surveillance which you will do in a high risk individual. MRI कर रहे हैं तो मैमोग्राम क्यों करना है? बात भी बिल्कुल सही है, बहुत अच्छा क्वेश्चन पूछा है. और MRI, can MRI see calcifications? No. MRI में बोन नहीं दिखती ना, तो कैल्सिफाइड चीज नहीं दिखती है. And one of the presentation of malignancy can be microcalcification, which is seen on a mammogram. That is? लॉजिक नहीं है इसमें, ये लॉजिक नहीं है जो लगा रहे हो. लॉजिक ये है कि मैमोग्राम has a limitation in less than 30-year-old. Don't we know? Don't we know? We know, na? In less than 30, mammogram is not going to be that helpful. That is why mammogram started at a year in a 30 years. ठीक है, नहीं तो हम 25 से ही कर देते शुरू. Okay? Now, then comes, now once हमने क्या किया? How will a patient of carcinoma breast is going to present to us? With lump breast. Okay. And what are we going to do? Clinical examination, radiology, and then tissue sampling. And in that tissue sampling, what tissue sampling? True cut biopsy. अब true cut biopsy हमने करी. Once we have done a true cut biopsy, what all information you want to gather from this true cut biopsy? Histopathology पता लगेगा? Will we come to know what is the type of cancer it is? Yes or no? Okay. Not only we want to know the pathology of the tumor, we also want to know what is the status of estrogen and progesterone receptor on this tumor, whether the estrogen and progesterone receptors are there in this tumor or not. So we want to know ER, PR, receptor status also. So they can ask you what all information you want to know through true cut biopsy. So it is not only that we want to know the pathology of the type of cancer, we also want to know ER, PR status. We also want to know HER2 new status. Want to know the grade of the tumor. These are the 4 things we would like to know in a patient of a lump breast in true cut biopsy. Okay, right? Now correct me if I'm wrong. After this, my diagnosis of carcinoma breast is established. Yes or no? It is confirmed that my patient is suffering from a breast malignancy. So what I'm going to do now, what should I do now? I have to decide the management. To decide the management, I have to first do the I have to first make out what stage the patient is in. And let me tell you, carcinoma breast staging is very, very important for us. Not only that, we need to know the TNNM. We are also supposed to know the stage as per TNNM. And I'll give you a very simple way of remembering it. What I'm going to do here, see, my primary objective here is, those who have my notes already, they can see that my approach in a subject has changed. The way I used to teach, it is not the same, because I am more focused now on a clinical part of the subject. And at the same time, I'm covering the theoretical points also with the clinical thing, right? In this staging, what I'm going to do, because see what happened is, what I can feel that you have to now know the theoretical point also, and you also have to know the clinical part. So that means earlier we were just focusing on the theoretical part. We were not focusing on the clinical part. So earlier the bulk surgery already a bulky subject. The bulk was still lesser. That bulk was already more, but it was still lesser than what we have now. So what I'm trying to do here, that I will going to give you the things which we, if remember, we should be able to solve any question. And I'm trying to keep those things limited so that there is lesser things to remember. Okay, so in staging, there is T, there is N, and there is M. We have to remember T and M here, right? And in that T, TIS is in situ carcinoma. TIS is in situ carcinoma. And what is very, very important now, as per the latest, which was not there earlier, those who have my notes, please change it. It includes ductal carcinoma in situ and Paget's disease without invasive malignancy. And what has changed in this is, earlier lobular carcinoma in situ was also there in TIS, which is now being removed. Lobular carcinoma in situ is out of this TIS, right? Then comes T1. T1 is less than 2 centimeter. T2 is 2 to 5 centimeter. T3 is more than 5 centimeter. T3 is more than 5 centimeter. T4 is further divided into 4A, 4B, 4C, and 4D. T4 is further divided into 4A, 4B, 4C, and 4D. 4A is any size with chest wall involvement. Any size with chest wall involvement. And please highlight it in your notes. Chest wall involvement does not include pectoralis major muscle involvement. Pectoralis major muscle involvement. T4B is any size with skin involvement. Any size with skin involvement. And in this skin involvement, please highlight it again. Skin involvement includes body orange appearance, satellite nodule, and ulceration. It is orange peel appearance. It is orange peel appearance. T4C is 4A and 4B together. T4C is 4A and 4B together. 4D is inflammatory carcinoma. 4D is inflammatory carcinoma, right? N0 is no node. N1 is ipsilateral mobile, and one is ipsilateral mobile axillary lymph node, ipsilateral mobile axillary lymph node, and 2 is 2A and 2B. And 2A is ipsilateral fixed or matted axillary lymph node, and 2B is ipsilateral internal memory lymph node, and 2B is ipsilateral internal memory lymph node in absence of axillary lymph node, and 2B is ipsilateral internal memory lymph node in absence of axillary lymph node. ये स्टेजिंग आपको याद करनी ही पड़ेगी. There is no other way. ipsilateral मतलब जिस साइड पे लंप है उसी साइड के lymph node. 2B is ipsilateral internal memory lymph node in absence of axillary lymph node. मतलब axillary lymph node नहीं है, सिर्फ internal memory. And 3A is ipsilateral infraclavicular lymph node, that is apical lymph node. And 3B is ipsilateral internal memory lymph node with axillary lymph node. And 3C is ipsilateral supraclavicular lymph node. And 3C is ipsilateral supraclavicular lymph node. Okay, now imagine, now let's understand this, because understanding the staging is more important. Just remembering will not help. Now imagine a patient comes to you with a 2 centimeter lump in the breast. What is the T of this patient? T2? 2 centimeter है. Less than 2 centimeter है. It is, write it here. It is P1. Less than or equal to 2 centimeter will come in T1. 5 centimeter, that means comes in T2. Then comes, imagine a patient comes to you with a 2 centimeter lump in the breast, which is tethered. These are very important points. Which is tethered to skin. T4 B. Answer T4 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 B. You are absolutely wrong. It is T1. And what is T4B? And what is skin involvement? What is teether? What is teether? I told you what is puckering, what is teethering, what is dimpling, and what was that involvement of? Ligament of Cooper. Ligament of Cooper. So is it skin involvement? Then why T4B? It is T1. Okay. Another question. Another question. Patient comes to you with a 2 centimeter lump in the breast with bilateral supraclavicular lymph node enlargement. What is a TNL? T1, T1, T4B. आज कुछ तूफानी करते हैं तो T4B हो गया, T4B हो गया. T4 क्या है? देखो T4B क्या है जरा. Satellite nodule supraclavicular lymph node. N3C, but bilateral है तो M1. Ipsilateral supraclavicular is N3C. Ipsilateral supraclavicular is N3C. Opposite side supraclavicular will get enlarged. It is a distant metastasis. Please note, if opposite side supraclavicular lymph node get enlarged, it is considered as a distant metastasis. It is considered as a distant metastasis. Understood? Okay. Sure. Now, let us know the staging. हाँ? M नहीं लिखवाई तो अब लिख ले. M0 is no distant metastasis. M1 is distant metastasis. दिल पे मत लेना, ठीक है ना? Okay. Now, staging. Now, when I was at your level, even today, I find it very difficult to remember T1 N0 N0, T2 N0 N0 is stage 1, stage 2. Very difficult. I've kind of simplified it for myself. Now it is for you also. You have to just remember these 3 things. If you remember these 3 things, you can answer any question on staging. Let's see what. If there is any T, any N, if there is M1, what stage is it? There are 4 stages in any malignancy. Stage 1 to stage 4. It is stage 4? Pakka? So it is stage 4. So that means you already know it. So that means you don't have to remember it. If you still want to, you can. Once there is a distant metastasis, it is a stage 4 disease. There is no confusion. Pakka. So what we have to remember is this. Stage 1 is always T1 N0 M0. Stage 1 is always T1 N0 M0. Stage 2 is any lump less than 5 centimeter with lymph node, any lump less than 5 centimeter with lymph node, or more than 2 centimeter without lymph node. Any lump less than 5 centimeter with lymph node, or any lump more than 2 centimeter without lymph node is stage 2. Whatever in between is stage 3. Whatever in between is stage 3. So let's make it further simpler. Whenever it is T4, remember, whenever it is T4 or it is N2 or it is N3, whenever it is T4, whenever there is N2 or there is N3, it is always going to be stage 3. So इसका मतलब है this lymph node we are talking about here is N1. N2 और N3 तो इधर आ गया ना. अब ये वर्किंग फॉर्मूला है, ये इस वर्किंग फॉर्मूला से हम स्टेज निकालेंगे. ये वर्किंग फॉर्मूला अप्लाई करना आना होगा, सिर्फ ये रटने से नहीं होगा. You have to know how to apply this working formula. Let's apply. So tell me, patient comes to you with a 2 centimeter lump in the breast. सिर्फ टी से तो स्टेज हो ही नहीं सकती ना. This is called pregnant with thoughts. Just delivered. So patient comes to you with a 2 centimeter lump in the breast with satellite nodule, with no lymph node, with no distant metastasis. What is a stage? Stage 2 centimeter lump with satellite nodule, with no lymph node, with no distant metastasis. What is T here? T4B. So movement it is T4. What stage is it? Stage 3. Movement it is T4. It is stage 3. We know that. Okay, another question. Patient comes to you with a 6 centimeter lump in the breast, with matted lymph node in the axilla. With matted lymph node in the axilla. With no distant metastasis. Stage. Movement it is N2. Movement it is N3. Stage 3. सबको समझ आ रहा है? पक्का? हाँ? Patient comes to you with a 6 centimeter lump in the breast, with matted lymph node in the axilla, with no distant metastasis. What is T? What is T here? What is T here? T3. What is N here? N2. And movement there is N2. Movement there is N2. Movement there is N3. ठीक है ना? Another question. If you answer this, you understood the formula. So let's see. Patient comes to you with a 6 centimeter lump in the breast, with ipsilateral mobile axillary lymph node.
Stage 2.
जल्दी कोई नहीं है, जल्दी नहीं है. Ipsilateral. जब क्वेश्चन नहीं सुना तो आंसर दीजिए. 6 centimeter lump with ipsilateral mobile axillary lymph node. Stage 4. क्या कुछ तूफानी करना है? 6 centimeter. आंसर क्या है? अच्छा चलो इसको समझते हैं। क्या ये है? नहीं है। क्या ये है? क्या ये है? तो फिर क्या बचा? तो जब वो स्टेज 1 नहीं है, स्टेज 2 नहीं है, स्टेज 4 नहीं है, तो कुछ तो होगा। और बचा क्या है? 3। श्योर? बाउंसर तो नहीं जा रहा है? बाउंसर तो नहीं जा रहा है? लॉर्ड्स में नहीं खेलना हमें खेलना है चिन्ना स्वामी में। सबके बाद में लगेंगे, ठीक है? समझ आया? चले आगे। ये दिल मांगे मोर। ओके। Patient comes to you with a 8 centimeter lump in the breast, with no lymph node in the axilla, with no distant metastasis. दोबारा देखो। 8 centimeter, no lymph node, no metastasis. 4. जो कोई आंसर नहीं करेगा वो करूंगा, ये सोच के आए हो? ये क्या था? 2 से 5। ये क्या है? मोर देन 2 सेंटीमीटर नहीं है। लिम्फ नोड है तो सामने तो है।
सर वो
क्या हो रहा है? वो
सर ये वाला ये हटा दिए सर।
क्यों हटा दो?
सर
ठीक है, चले आगे। पक्का देखो, आप क्वेश्चन करना और असेस करना कि कर पा रहे हो, ठीक है? आप कर पाओ। अच्छा, ओके। A patient comes to you with a 6 centimeter lump in the breast, which is invading pectoralis major muscle, with no lymph node in the axilla, with no distant metastasis. One, 4. आज का सबका आंसर 4 ही करना है। देखो पहले सामने देखो क्या 6 सेंटीमीटर लंप with invasion of pectoralis major muscle। T क्या है इसमें?
T4A।
T क्या है? T4 है। T4 है। It is T3, N0, M0. So what is the stage? Stage 2. अब ठीक है, पक्का? चले आगे। Now, this stage 1 and stage 2. Stage 1. This was also one of the question in your exam. Stage 1 and stage 2 is called early breast cancer. Stage 1 and stage 2 is called early breast cancer. Stage 3 is called locally advanced breast cancer. Stage 3 is called locally advanced breast cancer. And stage 4 is called advanced breast cancer. Stage 1 and stage 2, early breast cancer. Stage 3, locally advanced breast cancer. Locally advanced breast cancer. Stage 4 is advanced breast cancer. Locally advanced. Okay. Now what we have done? We have done the staging. सबसे पहले हमने डायग्नोसिस किया, फिर हमने स्टेजिंग करी. अब now we will manage. Now we will do the management of a patient of carcinoma breast. ग्रेड, ट्यूमर का ग्रेड, कितनी फास्ट सेल्स मल्टीप्लाई कर रहे हैं इसे कहते हैं ग्रेड. ओके, नाउ मैनेजमेंट. इन मैनेजमेंट we have the option of surgery. We have the option of surgery. We have the option of chemotherapy. We have the option of chemotherapy. Sorry. We have the option of chemotherapy. We have the option of radiotherapy. We also have the option of target therapy. In management of a patient of carcinoma breast, we have the option of chemo, we have the option of radio, and we also have the option of target therapy. Target therapy. In target therapy, we have hormone therapy. In target therapy, we have hormone therapy and we have monoclonal antibody also. In target therapy, we have hormone therapy and we have monoclonal antibody also. Okay. Now, out of these various modalities, surgery is the primary or main modality. Surgery is the primary or the main modality. All these are the helping modalities. All these are the helping modalities or adjunct modalities. All these are helping or जिसको कहते हैं adjunct modalities also. Okay. Now let us start with chemo first. Let us start with chemo first. These are the helping modalities. हमें कब ये modalities देनी है? When are we supposed to give these modalities? Okay. First of all, chemotherapy which we give here is multi-drug therapy. And in that preferred is ACT. What is ACT? Adriamycin, cyclophosphamide, and taxanes. What are taxanes? Paclitaxel. If it is not there in your choice, if ACT is not there in your choice, then it is CAF. If ACT is not there in your choice, then it is CAF. What is CAF? कुछ भी. Cyclophosphamide, adramycin, 5-fluorouracil. Cyclophosphamide, adramycin, 5-fluorouracil. Cyclophosphamide, adramycin and 5-fluorouracil. Okay, अब these are the chemotherapies which we are going to give. But when to give? When are we going to give a chemotherapy? The indications of chemotherapy are, just remember these two. Indications of chemotherapy are: 1. Indications of chemotherapy are: 1. Once the lymph node is positive of malignant cells, once the malignant cell is found in the lymph node, when you find a malignant cell inside the lymph node, it is chemotherapy you have to give. Second, if the size of the tumor is more than 1 centimeter. Once the size of the tumor is more than 1 centimeter, then also we need to give chemotherapy. So these are the indications of chemotherapy. Then comes radiotherapy. Then comes radiotherapy. Now, एक basic point है which you should know. The basic point here is, whenever we give chemotherapy, chemotherapy कैसे देते? IV line से. We give chemotherapy through the IV line. So that means chemotherapy is going to act in the blood also. Chemotherapy is going to act at the local site also. Chemotherapy is going to act in the blood also, and it is going to act at the local site. It will kill the cells in the blood also. It will kill the cells in the lump also. But radiotherapy, when we give, radiotherapy only has a role at the local site. Radiotherapy never has a role in the blood. So it doesn't have a systemic control. It only controls the disease locally, right? So radiotherapy controls the disease locally. And when to give radiotherapy? 1. The indications of radiotherapy are: 1. Once the lymph node is positive, even a single lymph node positive is there, the latest guideline says you have to give radiotherapy. Second, when you have a positive margin. When you have a positive margin. These are the two indications of giving a radiotherapy. Positive margin मतलब आपने ट्यूमर को निकाला, ट्यूमर निकालने के बाद जो माइक्रोस्कोपिकली ट्यूमर के अराउंड जो टिश्यू था उसमें भी मैलिग्नेंट सेल थे, राइट? तो इसका मतलब मैलिग्नेंट सेल पेशेंट की बॉडी में भी है, right? So positive margin or lymph node positive are the two indications of giving radiotherapy. Now then comes hormone therapy. When to give hormone therapy? The hormone therapy is given when estrogen and progesterone receptors are positive. Hormone therapy is given when estrogen and progesterone receptors are positive. Estrogen and progesterone receptors on tumors are positive. Now, what are the hormone therapies we have? We should know, and what hormone therapy we are going to give when. These are the two important issues. In hormone therapy, we have the option of SERM. We have the option of SERM. What is SERM? Selective estrogen receptor modulator. Very good. We have the option of aromatase inhibitor. We have the option of aromatase inhibitor. And we also have the option of GnRH analogs or bilateral oophorectomy. We also have the option of GnRH analog or bilateral oophorectomy. Removal of both the ovaries. Both the ovaries. Now, in selective estrogen receptor modulators, we have the option of tamoxifen. In selective estrogen receptor modulators, we have the option of tamoxifen, and we also have the option of raloxifene. We have the option of tamoxifen. We have the option of raloxifene. We prefer tamoxifen. Yeah.
Breast cancer.
What are you saying? It leads to carcinoma endometrium. It is a therapy for. We are talking about management of carcinoma breast, and so saying tamoxifen is the etiology for carcinoma breast. It is other way around. It is other way around. You are getting confused. Tamoxifen or raloxifene. Preferred is tamoxifen. Preferred is tamoxifen, and it is given at a dose of 20 mg OD. And earlier it was said that it should be given for 5 years. Now it is said that we should give it for 10 years. Earlier, tamoxifen was said to be given for 5 years. Now it is said that it should be given for 10 years. Right? The duration has now got prolonged. And the most common complication of tamoxifen, a question very commonly asked, it is hot flushes. Most common complication of tamoxifen is hot flushes, while the most common complication with long-term administration, most common complication of tamoxifen with long-term administration, please be careful about it. It is carcinoma endometrium. It is carcinoma endometrium. Right? Now, aromatase inhibitors include letrozole. Aromatase inhibitors include letrozole, N-estrazole, and X-mestane. Aromatase inhibitors include letrozole, N-estrazole, and X-mestane. Out of these three, now preferred is letrozole. is levetrazole. It is levetrazole. Now, very important point. SARMs, please understand these points. SARMs are going to be effective in both pre and post-menopausal patients. Yes or no? SARMs are effective in both pre and post-menopausal patient, mind it. While aromatase inhibitors are only effective in post-menopausal patients. Aromatase inhibitors are only effective when the ovaries are non-functioning. Otherwise, there is no point of blocking the aromatase enzyme which is present on a peripheral fat. If the peripheral fat stops producing estrogen, if ovaries are still producing, there is no point, right? So they are going to be effective only in a non-functioning ovary patient or a post-menopausal patient. Now, a very important point, and which they keep asking in your exam, is a change in the guidelines also on this. If you are asked, what is the drug of choice in hormone therapy? If you are asked, what is a drug of choice in hormone therapy in premenopausal patients? What will be your answer? Without confusion, without any confusion, it is tamoxifen. But if the question comes, what is a drug of choice in hormone therapy in post-menopausal patients? Now it is levetrazole. And if in your given exam, they ask you, what is a drug of choice in hormone therapy in general, without specifying pre and post? Answer now is aromatase inhibitor, and that is levetrazole. Answer now is aromatase inhibitor, that is levetrazole. Okay. Now, these are the indications of the hormone therapy, and this is how we are going to decide which hormone therapy are we going to give in a given scenario. Then comes monoclonal antibody. This monoclonal antibody includes Herceptin, which is also called trastuzumab. This monoclonal antibody includes Herceptin or trastuzumab. It also now includes pertuzumab. It also now includes pertuzumab. And very important point in this, when to give this monoclonal antibody? This monoclonal antibody is to be given when HER2 new is positive or overexpressed. When HER2 new is positive or overexpressed, we are supposed to give this monoclonal antibody. Now what I'm going to make you write down, every word in that statement has an MCQ. Now what is this HER2 new? What is this HER2 new? A question asked. HER2 new is a signal. It's a first of all growth factor. HER2 new is a growth factor. It is a signal transduction protein. It is a signal transduction protein linked with tyrosine kinase receptor, signal transduction protein linked with tyrosine kinase receptor encoded by a 2 gene. Encoded by a 2 gene. So in this growth factor is an MCQ, signal transduction protein is an MCQ, tyrosine kinase receptor is an MCQ, or 2 gene is an MCQ. Right? And whenever HER2/neu is overexpressed, we have to give a monoclonal antibody. And now, as per the latest, both should be given. Both of them should be given. As per the latest, not only we have to give Herceptin, we have to give pertuzumab also. We have to give pertuzumab also. Okay. Now, then comes surgery. Then comes surgery. In surgery, what are the options we have? In surgery, what are the options we have? The options we have in surgery are total or simple mastectomy, total or simple mastectomy, radical mastectomy. What is another name of radical mastectomy? Halstead's mastectomy. Modified radical mastectomy. What is another name? Petty's mastectomy. And now we also have an option of BCT. What is BCT? Breast conservative treatment. Breast conservative treatment. Breast conservative treatment. Okay, now we are not doing this surgery. We prefer doing a MRM. Now, what is this MRM? I already told you. Total mastectomy with removal of pectoralis minor muscle with lymph node removal. And what is that lymph node removal? Important. Level 1 to level 3. What is level 1? What is level 2? What is level 3? You already know now. Right? Now, please understand this point. Now, in the latest type of MRM, please listen to this. In the latest type of MRM, this is a Petty's MRM, which I just told you. Right? This is a Petty's MRM, which we know. But now we don't do this Petty's MRM. We do the type of MRM which we do now is called Etch-in-Clause MRM. What is important for us to note? तो समझो इस बात. If somebody asks you what is Petty's MRM, Petty's MRM remains same, but it is just that we don't do Petty's MRM anymore. We do Etch-in-Clause MRM. So what is Etch-in-Clause MRM? In this, we do total mastectomy as we were doing in Petty's also, but we are not removing pectoralis minor muscle anymore. We are retracting pectoralis minor muscle. We are retracting pectoralis minor muscle. We don't remove it, we just retract it. Means if this is a pectoralis minor muscle, we can retract it medially like this. We can retract with a retractor laterally like this. And once we remove the retractor, the muscle is still there. We We don't remove it. So we just retract the muscle. And we should also know an important point. We should also know the important point here. The extent of lymph node removal. The extent of lymph node removal here in this latest type of MRM is level 1 and level 2 always. Level 3 if enlarged. We have to remove level 1 and level 2 always. Level 3 we will only remove when it is enlarged. Level 3 we will only remove when level 3 lymph nodes are enlarged. Okay. This is the MRM we are doing now. This is called etching clause MRM. Okay. Now, the most common, very commonly asked question, the most common complication of MRM, the most common complication of MRM is seroma formation. Most common complication of MRM is seroma formation. Most common nerve injury in MRM is intercostobrachial nerve injury. Most common nerve injury in MRM is intercostobrachial nerve injury. Most common nerve injury, intercostobrachial. Most common complication is seroma formation. Most common long-term or most common disabling. Please be careful about these terms. Most common long-term, most common disabling, or most common severe complication of MRM is lymphedema. Most common long-term, most common disabling, most common severe complication of MRM fast, it will be lymphedema. And very, very important point to note, this lymphedema in 10 to 15 years, this lymphedema over 10 to 15 years will progress to angiosarcoma. It is going to progress to angiosarcoma, and this progression of lymphedema to angiosarcoma is called Stewart-Treves syndrome. This progression of lymphedema to lymphangiosarcoma is called Stewart-Treves syndrome. This progression of lymphedema to lymphangiosarcoma is called Stewart-Treves syndrome. Now, अब ये हमने theoretical points तो लिख लिए, but they are not going to ask you question like this. They will ask you the same question they'll frame in a different way. What is that way? Let's understand. Let's know the clinical part now. They will ask you, a patient underwent MRM. Patient underwent MRM. After MRM, the patient started complaining of sensory loss over the medial aspect of the upper arm. Which of the following nerve injury is the most likely cause? Intercostobrachial nerve. So what we need to know, this intercostobrachial nerve injury, which is the most common injury, if happens, it leads to sensory loss over the medial aspect of upper arm. Then, what other way they are going to ask this question? Very, these are important points. आप किसी भी पेशेंट से सर्जरी के लिए कंसेंट लेते हैं, right? Without the consent, you don't do surgery. So, whenever you take a consent from a patient, because this nerve injury is a very common nerve injury, so you should always specifically tell this patient that after this surgery, you may have a anesthesia over the medial aspect of the upper arm. You have to specifically mention. So how will they ask this question? They will ask that a patient is planned for a MRM because of carcinoma breast. Which of the following nerve injury complication you should specifically mention? Because it's a most common nerve injury in this surgery. It is not that we will not ask about other nerve injury, we will not tell about other nerve injuries. There can be injury to nerve to serratus anterior. There will be problem in the winging of scapula. There can be injury to thoracodorsal nerve. These are not common nerve injuries. The most common nerve injury is this. So you should tell patients specifically that after this surgery, you will have a sensory loss over the medial aspect of the upper arm. Because this is a very common. Then comes the question on lymphedema. How will they present this question? They can ask you that a patient underwent MRI. After 6 months of the procedure, now patient started complaining of swelling in her arm on the side where the MRM was done. And she is also complaining of a dull aching pain. What could be the most likely reasons? This is lymphedema. This is lymphedema. So how lymphedema presents? Lymphedema is going to present to us with a swelling, gradually increasing swelling, of ipsilateral arm with a dull aching pain. With a dull aching pain. Now, very important, they can ask you, देखो अब क्या है, मैं तुम्हें एक चीज बताऊं. How you should go about in your exam. As a faculty, I can tell you this. What they expect now, that as a MBBS doctor, you should be in a position to diagnose important clinical conditions which are commonly seen, and you should be able to manage them also. So all those things you keep asking that what is important for our exams. You can take it from here that all those things which we keep seeing in our emergencies very frequently, all those things as a surgeon which we keep seeing in our OPDs, we should know how to diagnose them. We should also know some of the overview of managing those conditions also. They don't expect you to know the detail of that, but they want you to know the basic outline on management, basic approach in management, so that you should be able to manage a patient once a patient comes to us. They don't want a doctor who just knows what is most common and what is least common. And what is very soon going to happen in your exam, they will not ask you which of the following is not seen in this condition, or all of the following are seen except. This was a discussion in the faculty NEET which happened. Where it was said that once students do MCQs, MCQ is the only way to check the students' knowledge. So when we do multiple MCQs, what happens is you must have come across this. When we do multiple MCQs, what happens is we tend to remember the answer. हमें आंसर याद रह जाता है. So आंसर जब याद रह जाता है तो ऐसे कई क्वेश्चन होते हैं जिसमें होता है which of the following is not seen in this condition. So that means मुझे क्या याद रहा? What is not seen. जबकि मुझे क्या याद रहना चाहिए था? What is seen. Why the hell I should know what is not seen? I should be knowing what is seen. So that is how now you will not have those negative questions in your exam. MLE, all these, bar exams, they don't ask all these negative, they are positive people. They don't ask all these negative things, right? You will never see in MLE or MRCS that which of the following is not seen in its condition. All of the following are seen except. They don't ask these type of questions. They are very methodical, that they want a doctor to identify a common problem and they want a doctor to manage that common problem also. And this is what is a change NMC pattern is asking us to do. Now, by 2023, all the medical colleges, this is the NMC guideline which we have to follow as a medical college, that there should be a skill lab. Every medical college is now told to, as soon as possible, by 23, we have to have that lab ready, which is called skill lab. And all the undergraduates will be trained how to do endotracheal intubation, how to do suturing, how to put a chest tube, how to do the wound management and all that. So that is why there is a gradual transformation from the pattern in exam is happening. That is why अभी धीरे-धीरे अभी जो NEET exam था, उसमें still there was single liner questions. तुम्हारे exam में भी there are few still single liner questions, but very soon the single liner question business is going to be out. They will just be talking about management part and approach part of a patients. And that is actually the way we should learn. Rather than knowing most common, least common, who cares what is most common or least common? If a particular problem is seen, very less commonly, it's a least common problem. If that problem happens to me, it is 100% problem for me, na? मुझे क्या फर्क पड़ता है किसी को होती नहीं होती, मुझे तो हो गई, किसी और को होती है नहीं होती, मेरे लिए तो 100% है। तो इसीलिए हमें वो प्रॉब्लम को आइडेंटिफाई करना और मैनेज करना, ये अब फोकस रखना है किसी भी सब्जेक्ट में, चाहे वो एनाटॉमी पढ़ रहे हो, चाहे वो बायोकेमिस्ट्री पढ़ रहे हो, यू हैव टू नो क्लिनिकल पार्ट ऑफ इट। अब सब कुछ क्लिनिकल हुआ, ओके, दिस इज द गाइडलाइन फ्रॉम एनएमसी, इट इज वेरी बोल्डली रिटन, ओके, सो दैट इज व्हाई यू शुड फोकस ऑन कि अब मान लो, अब आपसे they'll not ask you what is the most common, tell me what is the most common major complication of MRM. They will not ask you this. They will frame a question. A patient is coming to the swelling of the arm after underwent MRM. What could be the reason? The reason is lymphedema, right? So we should know how the problem is going to present, and then we should know what to do about that problem also. Now, once the patient develops lymphedema, what should I do? Huh? We will not do drainage. We will ask the patient to wear a compression garments, tight compression garments, and we ask the patient to keep the limb elevated. You should elevate the limb, and you should ask patient to wear a tight compression garments. Another very important point is, in any patient who has underwent MRM, because as an intern, you will be doing all this. You will be told, go and put a cannula in that patient. You as an intern will be told to put a cannula. Patient has a MRM done. So they can ask you, that patient has a MRM done on right side. You are an intern working in the hospital, and your senior resident tells you to put a cannula. On which arm you will put a cannula? You should never put a cannula on the arm on the side where the MRM is planned or done. You should put it on the opposite side. No trauma to the arm, which the side where the MRM is being planned or MRM is done. Okay, so these are some of the important points which we should know. This was about MRM. Then comes, there is something called BCT. Can we continue, no?
Yes, sir.
What is BCT? Breast conservative treatment. BCT is a breast conservative treatment. BCT is a combo of three things. BCT is a combo of three things. What are those three things? Lumpectomy, lymph node dissection, that is level 1, level 2 always, level 3 if enlarged, and also radiotherapy to breast. The combo of these three things is called BCT. The combo of these three things is called BCT. Now, this lymph node dissection, one should know, is also called axillary dissection or clearance. Axillary dissection or clearance. Okay, अब इसमें करते क्या है? Let's understand. What we are going to do in this procedure, let's know. Imagine this is the breast and this is the lump. What we are going to do in this procedure, we will excise this lump. I'll just tell you first overview and then I'll tell you the important intricacies in this. We will excise this lump, okay? Then through a separate incision in the axilla, we will do level 1, level 2 always, level 3 enlarged removal, right? And after this, we are going to give radiotherapy to the breast. First we do the surgery and after that we give a radiotherapy to the breast. So this is what we are going to do. Now in this, please note these points. What we are going to do, we will excise this lump, a black part. The lump is black part. We will excise this lump with a 1 centimeter margin. You were asking what is positive margin, now understand. So this lump with a 1 centimeter margin sent to the pathologist. We are waiting in the operating room. This is happening in the operating room. And in this pathology, we don't want a detailed report. What we want from the pathologist, that what is the status of the margin. If the pathologist says, I can't see any malignant cell in the margin, pathologist कहता है, margins are free of the tumor. I will close this incision and proceed to the axillary part of the surgery. I will close this incision and proceed to the axillary part of the surgery. But what if the pathologist tells me that margin is positive? Pathologist कहता है margin positive है, malignant cell मुझे दिख रहा है margin. Phone पे हो रहा है सब बातें. You will give another 1 centimeter margin to the pathologist. एक और 1 centimeter लोगे, send to the pathologist. अगर ये अब negative आ गया, we are done. अगर अभी भी positive आ गया, तो this is called persistently positive margin. This is called persistently positive margin. And once there is a persistently positive margin, you cannot do BCT. You have to convert this procedure to MRI. So this is what is BCT. So if you are asked, what is the margin of wide excision in carcinoma breast? Your answer is, what is a wide margin if you are asked in carcinoma breast? It is 1 centimeter. Wide margin if asked in carcinoma breast, it is 1 centimeter. You have to take 1 centimeter normal tissue around the breast malignancy. अंदर से और पड़ोसी का थोड़ी. राइट, किसी और का थोड़ी देखे. ठीक है. Now, what are the contraindications of BCT? What are the contraindications of BCT? The contraindication of BCT are pregnancy. Why? Huh? क्यों? ब्रेस्ट फीड करना इसलिए तो कॉन्ट्राइंडिकेशन तो इंडिकेशन होना चाहिए. अरे भाई ये है रीजन. रीजन इज MRM. प्रेगनेंसी इज एन कॉन्ट्राइंडिकेशन. कॉन्ट्राइंडिकेशन मतलब नहीं करनी है. Then persistently positive margin. Persistently positive margin. Then multicentric disease. Multicentric disease. Then connective active connective tissue disorders. Active connective tissue disorder except, please highlighted it, except rheumatoid arthritis. Except rheumatoid arthritis. Then history of previous therapeutic radiation exposure. History of previous therapeutic radiation exposure. Lump more than 5 centimeter in size. Lump more than 5 centimeter in size. Lump more than 5 centimeter. जहां पे कॉन्ट्राइंडिकेशन है BCT का MRM करे. Right? Lump more than 5 centimeter in size. Lump just beneath nipple areola complex. Lump just beneath nipple areola complex. These are the only contraindication of BCT now. Lump just beneath, and one more, sorry, family history or suspected hereditary carcinoma breast. Family history or a suspected hereditary carcinoma breast. नहीं है. Right? Now, then comes, so these are the contraindications to BCT. If you are not doing BCT, you will do MRM. Then there is another concept which has come up. That is called a concept of sentinel lymph node biopsy. The new concept has come up, which is called sentinel lymph node biopsy or flu node sampling. Just keep writing the theoretical points in this, and then I'll make you understand this. In this sentinel lymph node biopsy, the dyes used are, just keep writing, we will be discussing it, okay? The dyes used are radioisotope and plain dye. Radioisotope include technetium 99 labeled colloid sulfur. Plain dye include isophane blue or methylene blue. Isophane blue or methylene blue. Dye is injected peritumor and subareolar. Dye is injected peritumor and subareolar. अभी हम डिस्कस करेंगे इसको, जस्ट राइट डाउन, राइट? पेरिओरल एंड subareolar. The indications of sentinel lymph node biopsy are T1, T2, sometime T3 lesions. Contraindications are palpable lymph node. Indications are T1, T2, sometime T3 lesions. Contraindications are palpable lymph node, history of axillary surgery in past, history of radiation in past. These are the contraindications for sentinel lymph node biopsy. Most common complication of sentinel lymph node biopsy. Most common complication of sentinel lymph node biopsy is skin tattooing. If not in your choice, then it is intercostobrachial nerve injury. Skin tattooing, if not in your choice, then it is intercostobrachial nerve injury. Okay, so these were the theoretical things which I have written. Now let's understand this. देखो क्या है? You all know that all the lymph nodes in the body are sitting on a vessel. These are those vessels which are supplying that organ, right? And axillary artery is supplying breast. So we are doing a removal of axillary lymph node, but we know that axillary artery is also supplying the upper limb. So that means the lymphatic drainage of the upper limb is also going through the lymph nodes here, and we have removed them. So once we have removed them, what will happen to the limbs of this arm? There will be problems in the limb travel of this arm. So because of this lymphadenectomy, patients were developing lymphedema, the most common major complication I told you. So they came up with the idea that instead of removing lymph node in every patient, instead you should check whether the first draining lymph node has received a malignant cell or not. If the first draining lymph node has not received a malignant cell, try to understand, there is level 1, there is level 2, and then there is level 3. अगर malignant cell level 1 lymph node तक पहुंचा ही नहीं है, तो आपको lymph node निकालने से फायदा क्या हो रहा है? You are not getting any advantage by removing a lymph node. But if the level 1 lymph node has received a malignant cell, then it is prudent to remove a lymph nodes, because then the subsequent lymph node also might have received the malignant cells. So it is better, instead of removing lymph node invariably, you should check for a first draining lymph node. And this checking of a first draining lymph node of a malignant cell is called sentinel lymph node biopsy. This sentinel lymph node biopsy, अब हम करते कैसे हैं? What we do is, we have this lump. This all is happening in the OT. Everything is happening in the operating room. What we do? This is a lump. Okay, we inject a dye. We inject a dye, peritumor and subareolar. This is nipple-areolar complex. We inject a dye in the peritumor region and a subareolar region, right? And now this dye is injected, and now we will give a small incision in the axilla. We will just give a small incision in the axilla. Now what we do? We will put a gamma camera. Gamma camera detects radioactivity, and we are seeing with our naked eyes also. जो lymph node सबसे ज़्यादा radioactivity दिखा रही है, जो lymph node सबसे पहले blue हो गई, which is a level, that is a level 1 lymph node. We will take that lymph node out. We will take that lymph node out and we'll send it to the pathologist. We are waiting in the operating room. If the pathologist says that there is malignant cell inside, what should we do? We will extend this incision and proceed to level 1, level 2 always, level 3 if enlarged. But if the pathologist says there is no malignant cell inside, I will close this incision and I'm done with. And I'll just give radiotherapy to the breast. This is what is blue coloration of the skin of the side where you have injected it, and you should also tell your patient that you will be passing a blue urine for some days, because this blue, methylene blue and isophene blue, is excreted through urine and urine gets blue. And this sentinel node biopsy, very important, was first started in carcinoma penis. This concept of sentinel node biopsy was first started in carcinoma penis. Now this concept is valid in few malignancies. We should know what are those few malignancies where this concept is a valid concept. Penis, breast, melanoma, cervix cancer, endometrial cancer, and vulvar cancer. These are the malignancies where a sentinel lymph node biopsy concept is now a valid concept. Means in these malignancies, before doing a lymphadenectomy, we always do sentinel lymph node biopsy. In all these malignancies, we, before doing a lymphadenectomy, we always do sentinel lymph node biopsy. Understood? Level 1, no, we are just removing one lymph node. Okay, sure. Yeah. This, if the indications are there, if the indications of sentinel node biopsy are there and contraindications are not there, you should always do a sentinel node biopsy before doing a axillary dissection. Got it? Right? Chale aage. So this was about our surgeries. Now let us resolve the treatment of carcinoma breast as per stage. Let us now, what they expect from you in your exam, they will expect you to stage the disease on the basis of patient profile, and then they will expect you to manage that patient also on the basis of the stage. So if the patient is early breast cancer patient, the treatment of choice for that patient is BCT. If BCT is contraindicated, then MRN. treatment of choice for early breast cancer patient is BCT. If BCT is contraindicated, then MRM. Okay. For locally advanced breast cancer, the treatment of choice for locally advanced breast cancer is neoadjuvant chemotherapy. When we give chemotherapy before surgery, it is called neoadjuvant chemotherapy. When we give it after the surgery, it is called adjuvant chemotherapy. So MRM followed by chemo, followed by radiotherapy. The treatment of LABC is neoadjuvant chemotherapy, followed by MRM, followed by chemo, followed by radiotherapy. For advanced breast cancer, what is advanced breast cancer? NET, NEN with M1. NET, NEN with M1. Stage 4. The treatment is, if the patient is symptomatic, please understand this. Once the patient is symptomatic, second, or the patient is ER, PR negative. Once the patient is symptomatic or the patient is ER, PR negative, you will give chemotherapy. You will just give chemotherapy. If the patient is asymptomatic and ER, PR positive provided to you in given question, you will offer only hormone therapy. देखो एक बहुत important बात मैं बोलने वाला हूँ, and this point will be checked all throughout our end of the time in your exam. They check you on this point also. See, listen to this first and then write further thing. In any malignancy, remember there is a basic point to understand. In any malignancy, the malignancy is staged from stage 1 to stage 4. Every malignancy is staged from stage 1 to stage 4. Okay. In any malignancy, what is our primary objective in treatment? Our primary objective in treatment is survival. Our primary objective is survival, right? But once any malignancy goes into stage 4, what is stage 4? NET, NEN with M1. Once any malignancy goes into stage 4, every stage 4 malignancy patient has a average survival. Every stage 4 patient, हर malignancy के stage 4 patient का एक average survival होता है. There is an average survival for every stage 4 malignancy patient. And in stage 4 malignancy patients, we more or less, most of the time, we will not be able to prolong survival. Every stage 4 malignancy patient has a limited average survival. Since we can't do anything in survival most of the time in these patients, our primary objective shifts. Our primary objective shifts to a quality of life. Whatever life now this patient has, we want this patient to suffer the least. So our primary objective in a stage 4 malignancy patient is not survival. Our primary objective in stage 4 patient is whatever survival he has now, we want him to lead a as normal, as comfortable life as possible. So we will focus more on quality of life rather than survival in stage 4, right? So we will not be, we are not going to be very aggressive in managing a stage 4 patient. We will be just focusing on a quality of life. So in case of carcinoma breast, in stage 4 disease, once the patient is symptomatic or ERPR negative, we will just give chemotherapy. If the patient is asymptomatic and ERPR positive, we will just give hormone therapy. But if by any chance the patient has a fungating or ulcerative carcinoma breast, if by any chance patient has a fungating or ulcerative carcinoma breast, only in these two subset of patients we will offer surgery, and that surgery is simple. अब हम क्यों सर्जरी अदरवाइज ऑफर नहीं कर रहे? देखो, हमारा प्राइमरी फोकस है क्वालिटी. सर्जरी के लिए आपको जनरल एनेस्थीसिया देना पड़ेगा, and surgery has its own complications, and because of surgery also there can be a problem in the quality of life. So seroma, there are so many complications happening, so we will not offer surgery. But if imagine a patient has a cancer which has eroded the skin, it has come out of the skin and eroded the skin, it has become fungating, so this patient quality of life is getting deteriorated because of this fungating growth. So when you do surgery here, the quality is getting improved by the surgery. That is why we are doing surgery. Otherwise, we will not do surgery in a stage 4 carcinoma breast. Understood? So only in these two situations we will do this surgery, and after doing this surgery, if the patient is symptomatic and or ERPR negative, we'll give chemotherapy. If the patient is asymptomatic and ERPR positive, hormone therapy. Right? Hormone therapy. Got it? Now, if you got it, as you said, so answer. Listen to the question carefully and please don't disappoint me. I am trying to make you understand the concept in surgery. I am not one of those who will just give you points to mug up. I'll try my best to make you understand the thing so that you get wiser when you attempt the question. Question goes like this. Patient comes to you with a 4 centimeter lump in the breast with ipsilateral mobile axillary lymph node, found to have invasive ductal carcinoma on through-cut biopsy, which is ERPR positive. Patient comes to you with a 4 centimeter lump in the breast with ipsilateral mobile axillary lymph node, found to have invasive ductal carcinoma on through-cut biopsy, which is ERPR positive. Question पूरा हो जाए? क्वेश्चन पूरा कर दें? एग्जाम में भी यही होता है. जो क्वेश्चन आता है वो अगर जल्दबाजी के कारण गलत हो गया, उससे खराब कुछ नहीं लगेगा, क्योंकि आपको आता हुआ क्वेश्चन आपने खराब कर दिया. Ipsilateral mobile axillary lymph node. On through-cut biopsy, it is found to be invasive ductal carcinoma, which is ERPR positive. Which of the following is a most appropriate treatment option? Which of the following is a most appropriate treatment option? Let's see who answers this question right. First choice. Wide excision of the lump with axillary dissection. अगर ये क्वेश्चन किसी ने आंसर कर दिया तो आप कोई भी क्वेश्चन आंसर कर दोगे. जान ले लो मेरी. Patient comes to you with a 4 centimeter lump in the breast with ipsilateral mobile axillary lymph node, found to have invasive ductal carcinoma in true cut biopsy, and it is ER PR positive. Which of the following is most appropriate treatment? Choices are wide excision with axillary dissection on the basis of sentinel lymph node biopsy with radiotherapy and chemo and hormone therapy. Second, wide excision with axillary dissection with radiotherapy and chemo and hormone therapy. Wide excision with axillary dissection with radiotherapy and hormone therapy. MRM with hormone therapy. देखते हैं कौन आंसर करता है. Four, one, three. पांच तो ही नहीं यार. Four, one, four. Okay. One. Answer. C. 2. C. Okay. Let's hear from those who said 4. You said 4? Okay. Who said 4? Who said 4? You said 4. Right? Why 4? What is the stage? It is 3. It is stage. So stage 2, we prefer doing BCT. If BCT is contradicted, then is there any contradiction mentioned? Then why MRI? तो ये तो चॉइस ही गलत हो गई, ये तो गायब, तो बच गए 3. अब those who answered C, answered C. क्या सोचते हैं आंसर पे? सरदार खुश होगा, शाबाशी देगी. What is the size of the lump? 4 centimeter. And what is the indication of chemotherapy? So what is the size of the lump? 4 centimeter means more than 1. So that means chemo is on. Chemo is on, right? So answer can't be C. So that means answer now can be 1 or 2. Now who answered 2? Good round of applause for those who have answered 2. Very good, very good, very good, very good. But why? Very good. 1 क्यों नहीं है? 1 क्यों नहीं है? सेंटिनल थोड़ा वापसी करोगे? ये क्या लिखा था हमने? तू ही बोला था. Very good. So the answer is, so this was the understanding of the concept now. Now, if you understood, any doubt please. समझ आया सबको? पक्का? तो हमें क्या क्या सोचना है ट्रीटमेंट करने से पहले? हमारा दिमाग खुला कि नहीं? खुल गया? So the mind, your mind got open on the concept or not in deciding the treatment. Those who are listening online should also open their mind. So before deciding the management of a patient of carcinoma breast, we have to look at many aspects. Whether we should be doing a sentinel node biopsy or not, whether we should be doing a MRM or BCT or not, whether the patient needs a chemotherapy or not, whether the patient needs hormone therapy or not. That is how we will be deciding. Sure? Sure. So this was about our discussion on the management of a breast cancer. Continue?
Yes, sir. Yes, sir.
Let's continue till 10.
Yes, sir. Yes.
तो ऐसे हंस रहे हो जैसे पता नहीं मैंने क्या बात बोली. 10 तक चलने देते हैं. So let's finish off this one. In situ cancers. In situ cancers. In situ cancers, we have ductal carcinoma in situ. We have lobular carcinoma in situ. In situ cancers, we have DCIS and we have LCIS. Out of DCIS and LCIS, more common is DCIS. Out of DCIS and LCIS, more common is LCIS. Sorry, more common is DCIS. DCIS can be seen in male or female breast, while LCIS is only seen in female breast. It is not seen in a male breast. LCIS is not seen in a male breast. DCIS is an anatomical precursor. What do you mean by anatomical precursor? Anatomical precursor means once there is a ductal carcinoma in situ, it is any time in the life can transform into invasive ductal carcinoma. But it will always transform into an invasive ductal type only. So it can any time in life transforms into invasive cancer, and that invasive cancer will be invasive ductal only. Right? Ductal carcinoma in situ is an anatomical precursor. It means this carcinoma, when transforms into invasive cancer, it will always transform into invasive ductal type. Okay. Now, this lobular carcinoma in situ is now considered as a benign entity. This lobular carcinoma in situ is considered as a benign entity. An important point in this to notice, this can be bilateral. This can be multicentric. And this lobular carcinoma in situ commonly transforms into invasive ductal type. It is a lobular cancer, but it commonly transformed into invasive ductal type. And it is commonly, this bilateral point is very important. It is commonly bilateral, and it has Indian file pattern on histology. It has Indian file pattern on histology. What is that Indian file pattern? Not required. The cells are arranged one over another, like a file stacked in Indian offices. And in ductal carcinoma in situ, we just need to know most common presentation, most common microcalcification. Most common presentation of DCIS is microcalcification. Most common complication of, most common presentation of DCIS is microcalcification, and they will mainly check you on the management of DCIS. You should know the management of DCIS. In management of DCIS, we have the option of wide excision alone. We have the option of wide excision with radiotherapy, and we have the option of mastectomy, total mastectomy. We have the option of wide excision with radiotherapy. We have the option of total mastectomy. We have the option of wide excision alone. These are the three treatment options we have for a DCIS. And out of these three treatment options, the preferred one is this. Preferred one is wide excision with radiotherapy. The preferred treatment option for a DCIS is wide excision with radiotherapy. And please highlight it in the notes. Chemotherapy has no role in DCIS. Chemotherapy has no role in DCIS. Chemotherapy has no role in DCIS. In case of lobular carcinoma in situ, if you are asked what is the best treatment option, if you are asked what is the best treatment option for lobular carcinoma in situ, your answer should be bilateral mastectomy. But if they ask you what is the treatment of choice for LCIS, your answer should be observation with annual mammogram. Observation with annual mammogram. Right? क्योंकि लॉबुलर है और फिर भी ये देखो इसको एनाटॉमिकल प्रिकर्सर इसलिए बोलते हैं. Why do we call it anatomical precursor? Because once it is there, it is always going to transform into invasive cancer. Okay. Then we should also know few things about a special type of cancer of breast, that is inflammatory carcinoma breast. Inflammatory carcinoma breast is one type of carcinoma breast which has a worst prognosis. Inflammatory carcinoma breast is one type of carcinoma breast which has a worse prognosis, and it is seen in young patients. It is seen in young patients. And how do these patients present? This is very classical. Sudden, severe, painful enlargement of breast. Sudden, severe, painful enlargement of the breast. And on examination, you'll find enlarged, engorged, tender breast. On examination, you will find enlarged, engorged, tender breast. Now, you can appreciate, if you look at the presentation, you can appreciate this can be a presentation of a breast abscess also. This can be a presentation of a breast abscess. So, how will we know that are we dealing with a breast abscess or we are dealing with an inflammatory carcinoma breast? So, the telltale sign of inflammatory, a question very commonly asked, the telltale sign of inflammatory carcinoma breast is, the telltale sign of inflammatory carcinoma breast is presence of malignant cells in dermal lymphatic. The telltale sign of inflammatory carcinoma breast is presence of malignant cells in dermal lymphatic. Now let us see who will answer this question. What is the treatment of inflammatory carcinoma breast? Let's see who answers this. What is the treatment of inflammatory carcinoma breast? किस लॉजिक से दे रहे हो? कोई लॉजिक से दे रहे हो या मन कर रहा है? मन से दे रहे हो? मन से नहीं होता काम ना. हमें ट्रीटमेंट, we have to answer treatment according to the stage. सोचो. It is stage 3. And what is the statement of stage 3? Chemo followed by MRI, followed by chemo, followed by radiation. Why it is stage 3? देखो, why it is stage 3? Inflammatory carcinoma is 4, and once it is T4, it is always stage 3. And what is the treatment of stage 3? Neoadjuvant chemo, followed by MRM, followed by chemo, followed by RT. But logic नहीं था ना, मैं बोला नहीं था पर सर क्वेश्चन में तो आंसर से फर्क पड़ता है. आंसर ठीक तो सब ठीक. Okay, understood? Can we go ahead? Then comes Paget's disease. Paget's disease. Paget disease is a superficial skin manifestation of underlying malignancy. Paget's disease is a superficial skin manifestation of underlying malignancy, and that underlying malignancy can be DCIS, can be invasive ductal cancer. That underlying malignancy can be DCIS, can be invasive ductal cancer. Now, how do these patients, this is a very classical presentation. This presentation is important because they will present you with this profile of a patient, and then they expect you to make a diagnosis and manage it also, and decide the investigation also. So how do these patient presents? It is first of all commonly a unilateral disease. It is first of all commonly a unilateral disease. And how do these patients present? They present to you with an eczematous rash over nipple areola complex with or without underlying lump. Patient presents to you with a eczematous rash over nipple areola complex with or without underlying lump. They will come to you with a rash over a unilateral breast at a nipple areola complex. This is very classical about it. Investigation of choice for these patients is skin biopsy. Investigation of choice for these patients is skin biopsy. And in skin biopsy of these patients, you will find Paget cells. You will find Paget cells which are positive for, you will find Paget cells which are positive for CEA, cytokeratin, and PAS, but negative for S100. In the biopsy of a Paget disease, in the skin biopsy of a patient of Paget disease, you will find Paget cells which are positive for CEA, cytokeratin, and PAS, but negative for S100. And now Paget cells पे Paget cells तो लिखा नहीं रहेगा. They have to have certain features. So what are the features of Paget cells? We should know. What are the features of Paget cells? We should know. The features of Paget cells is, these are large, clear, vacuolated cytoplasmic cells. If you find a large cell with a clear vacuolated cytoplasm, it is a Paget cell. And the treatment of choice for Paget disease is simple or total mastectomy. So please be very careful in your given clinical profile. If the examiner gives you a profile of a patient who has a rash on a unilateral breast at nipple areola complex, the first thing that should strike your mind should be Paget disease, right? And in Paget disease, the confirmation of diagnosis happens by a skin biopsy. Okay. Then comes the most important, very commonly asked question, and there's a lot of confusion on this question also. Most important prognostic factor in carcinoma. Very commonly asked question it is, and there's a lot of confusion on this. The most important prognostic factor. Now tell me, what do you understand by prognosis? Survival. So if I tell you one patient is stage 1, another patient is stage 2, what will you say? Stage 1 will have a better. So most important thing is stage. So most important prognostic factor if asked is lymph node status. If the stage is not there in your choice, then it will be lymph node status minded. But please be very careful further. If you are asked what is the most important prognostic factor in advanced or metastatic carcinoma breast, advanced or metastatic carcinoma breast is specified, then the answer will be ER, PR, receptor status. Then it is ER, PR, receptor status. This is the latest. Okay. And then you should also know this latest classification, a molecular classification of carcinoma breast. What is the molecular classification of carcinoma breast? First of all, you should note and highlight that also. This molecular classification of carcinoma breast is on the basis of gene expression. This molecular classification of carcinoma breast is on the basis of gene expression. And in this, there is luminal A, there is luminal B, there is HER2 amplified, there is triple negative, or which is also called basal light. This molecular classification is on the basis of gene expression, and in that it is divided into luminal A, luminal B, HER2 amplified, triple negative, or basal light. Luminal A is ER, PR positive, but HER2 negative. Luminal A is ER, PR positive, but HER2 negative. Luminal B is ER, PR positive, and HER2 also positive. HER2 amplified is AR, PR negative, but HER2 positive. Triple negative is AR, PR negative, and HER2 negative. And this is the most common type, and this is the least common type. And this has a worst prognosis also. And these are the things we need to know about carcinoma breast. Any question now? Any doubt, anything you have, don't keep it in your mind, please ask. Yeah, basement membrane. If the tumor cells are above the basement membrane, it is in situ. Once the tumor cell invade the basement membrane and come inside, it is invasive. Superficial. Any question? So you want me